Welcome back. We hope to complete the documentary in the middle of our program. But tonight, I couldn't have two better people to talk about the 10 years of the NHIS. My first guest is Honorable Retired Sylvester Mensah, Chief Executive of the National Health Insurance Authority. I call him Honorable Retired because at one time he was the youngest serving Member of Parliament for Dade Kotopong. And my second guest is Professor Kwabna Frimpong Boateng, former Chief Executive of the Kolebu Teaching Hospital. He's more known as a heart surgeon, but in this discussion, we want to listen to his views as having served as the head of the largest service provider to the NHIS. Welcome, gentlemen.
Thank you.
Thank you.
Yeah. Let's start with you, Sylvester. You are celebrating 10 years. Can you tell us what is there for us to celebrate after 10 years of the NHIS?
Thank you very much. It's my pleasure to be on your program.
Thank you.
And we haven't met for a very long time.
Yeah, I know.
But I'm glad to share your company this evening. Unfortunately, we are not celebrating. And what we're doing is we are commemorating. We have been very selective in our choice of words. And we are talking about commemorating 10 years of health insurance in Ghana. Celebration connotes something different. I think that
commemorating usually refers to
commemoration,
death or dying.
Well, commemoration has to do with taking stock,
yes.
Looking at the past, looking at the current, and re-strategizing into the future. And that is exactly what we intend to do. The whole idea of commemorating 10 years is to place health insurance in the hearts and minds of Ghanaians and to generate greater awareness of the existence of the scheme, and importantly to generate an international dialogue forum so that we could exchange ideas and experiences in redefining our next future.
But even in commemorating, I mean, we've done 10 years. So what was the vision and how far have we come? We set out to achieve something. And what did we set out to achieve, and in 10 years, what have we done?
Well, I guess you understand that better than I do. The whole idea was to ensure financial risk protection at the point of healthcare delivery so that subscribers or patients, for that matter, do not, as it were, get involved in catastrophic health expenditure that could generate some degree of impoverishment for the people of this country. The law was passed in 2003 and continued until 2012 when we had to review the law. I must say that the initiators of the law were bold and deserve some commendation, even though the new law, Act 852 of 2012, radically transforms what existed. I think that the Act 650 of 2003 succeeded in laying the foundation that has been deepened currently to provide an enhanced health insurance scheme, that is to say, an enhanced financial risk protection for the people of this country.
Let's put this in Dade Kotopong language. We set out to abolish cash and carry. How far have we succeeded?
I think that it's been quite useful. You would agree that doing away with cash and carry is a process and not an event. To the extent that it is a process, and looking at where we have come from, I think that significant progress has been made. Currently, data from particularly the Ghana Health Service from 2007, from 2008 running to date, have revealed tremendous improvement with regards to the quantum of funds that are generated from non-health insurance subscribers contributing to internally generated funds. The Ghana Health Service, for instance, in 2010, 2011, 2012, revealed in the annual report that over 85% of internally generated funds are derived from health insurance payments, and that just about 15% of internally generated funds come from out-of-pocket payment. This trend has been going down to date, and as we speak now, we are at a point of about 87 to 88% of internally generated funds being derived from health insurance payments. If we are to look at the statistics, then no one can say that there is no improvement. Besides, if we also want to look at active membership from day one to date, active membership in 2005 at the onset of the scheme was around 1.3 million. As at the close of 2012, active membership was close to 9 million, about 8.87 million. So you could say, but let me before I even end there, let me say that it is important when looking at active membership to also look at cumulative membership, even though cumulative membership may not be a good indicator of performance. Indeed, utilization is one of the key indicators of performance, and I mean, we're looking at international best practice and benchmarks and measures for, as it were, determining performance of health insurance schemes. Cumulative membership, when we look at the number of people who have ever registered on the scheme, who have ever held health insurance card on our records, is beyond 22 million. Active membership connotes those who are in good standing, those who have cards, have renewed by way of paying premium and are eligible to access healthcare using their health insurance card. And that is the 9 million that we're talking about.
We'll come to a discussion on the cumulative versus the active. But, Professor, you, at the time the health insurance system came, ran the biggest service provider in Ghana, Kolebu. What was the perceptible difference you saw between the onset of the scheme and the introduction of the scheme at the time that you were chief executive? What was right about it in between the two periods?
Thank you very much for having me on your program again.
Thank you.
I'm very happy to be with my friend Sylvester. I think they're doing a good job at the headquarters or the insurance system. The managers are doing well. Their challenges have to do with the general economy of Ghana. In Kolebu, it would be unfair to use Kolebu as a standard because at that time we were not even operating the system at all because the health insurance system could not cover a lot of the things that we were doing in the hospital, and in fact that is still the case. The insurance system, the premiums you pay cannot cover the services that are rendered in the major hospitals such as Kolebu. So that is the state of the, and I think it hasn't changed much.
But I thought one of the problems, one of the challenges of Kolebu and other teaching hospitals was that it was doing too much outpatient care, and that the outpatient care, I would have thought most of it will be covered by the health service.
No, see, the outpatient care, that is specialist outpatient care. I mean, what the insurance will cover will be the primary health care and some of the secondary area. But before you come to Kolebu, the outpatient care, it becomes different because then the investigations become more expensive, more specialized, and so on. So it is still very difficult to cover.
So it made no impact whatsoever in Kolebu?
Initially, it made no impact, but I think things may be different now.
Because my perception and sense of Kolebu was that perhaps too much time and resources were being devoted to people who were just walking in with headaches, etc., and all of that.
No, we can't walk into Kolebu. This is what I'm trying to say. That it's not not how Kolebu is programmed to do. It's a referral hospital, so people are referred to Kolebu, and so if you are referred from a scheme in the district to Kolebu, a lot of the things may be covered, but some of the major investigations major services rendered would not be covered by the insurance.
So which services were covered by Kolebu and how did you deal with it under the scheme?
I guess the outpatient care, maybe in the polyclinic, they render services which will be covered by the insurance. But when it comes to the major departments, obstetrics, there I guess because we had the free maternal care, that will also cover it. And but when it comes to heart surgery, when it comes to burns, when it comes to management of children with complications, then the insurance will not cover.
So what proportion would you say that, let's say, Kolebu's involvement with the health insurance system would be? 10, 15?
At the time that I was there, maybe it would have been between 10%.
Sylvester, I've heard a lot of numbers about finances, etc. But I want us, first of all, to put in the 10 years, for example, from your records, how many people, how many Ghanaians have been treated under the NHIS? And then, the prof said something which also then gives me a little worry, because I was under the impression that much of the treatment was taking place in the regional and district hospitals, many of which have now become tertiary institutions. And then there's always an issue of how far have the private medical practitioners been drawn into the scheme. So let's get some numbers. Over the last 10 years, according to your records, how many people have actually benefited from the scheme? Where are the principal points of treatment? And how are we dealing with the issue of private practitioners? I know it's a lot of questions.
Yeah,
that's what you're here for.
Yeah, thank you. Well, let me say that indeed, utilization is a key indicator of performance, and importantly, it also reflects the confidence level of the scheme by way of whether Ghanaians are getting more confidence in the scheme and are enrolling. If we want to go back to the onset, we may perhaps take too long a time.
No, we don't want to do that.
But if you look at the trend, particularly from 2008 to 2012, in 2012, the utilization was around 12 million in 2008. And when we talk of utilization, you're talking about the number of times the health insurance card has been used
that's what
in
I wanted
accessing
to know. Yes.
healthcare, irrespective of the fact that one person might have used it two times or three times. And of course, with the introduction of free maternal care and with the enrollment of mothers and accessing healthcare, free maternal care, one could have some of our mothers accessing healthcare perhaps
times,
6 times, 7 times in a year. In 2012, utilization had risen to around 22 to 23 million.
In the year?
Yeah, in 2012. If you put that against 2005, the very onset, utilization was just around 2.6 million.
The first year?
In the very first year. So you could see a gradual progression from 2.6 million to 12.6 thereabout million, and then to 22 to 23 million. This tells us that a lot more Ghanaians are currently accessing healthcare by the use of health insurance card, which in itself is a good indication that health insurance is making some headway. The whole purpose is to ensure financial risk protection. The whole purpose is to ensure that Ghanaians don't engage in self-medication, that they visit the hospital at the least provocation. Indeed, one can say that our health-seeking behavior as a Ghanaian, our health-seeking behaviors are changing by these statistics that we see. But having said that, it is important to say that we are still miles away from our target. And there are several combinations of or elements that come together in spicing each other to ensure that we get to our final destination. Indeed, as we speak today, if we talk about active membership at 9 million, then we are talking about 36% of the population. We are miles away from achieving universal health care. Yeah. But again, one could say clearly that looking at where we are coming from, there has been some progress. And what we need to do now is to intensify our efforts at education, at communicating, at awareness generation, and also building confidence in the people in order to ensure that all Ghanaians enroll. Indeed, the new law provides for a mandatory health insurance scheme. By the new law, every Ghanaian is supposed to enroll.
Are you introducing Obamacare in Ghana?
I don't know what Obamacare is.
Oh, you should.
But I mean,
Obamacare is the law that is making it mandatory for all Americans to take out.
Exactly, but I wouldn't call that Obamacare in Ghana. What we have is the Ghanaian version. Our model is certainly different from that of the.
Why are you making it mandatory?
Just to, you know, there are some basic principles that underlie any insurance scheme. The principle of solidarity, the principle of risk pooling. You need to pool risk from all Ghanaians in order to generate a quantum of resources for those who are sick at any particular time to, as it were. You know, when you go for a car insurance, you are able to get a replacement for your car in the event of an accident.
But it's not mandatory.
For the simple, I'm coming to that, for the simple reason that several other people are contributing to the insurance, and not everyone would suffer the event of an accident, and for which reason you're able to pool these resources to cater for those who are unfortunate to.
Before you go on to those discussions, one second, because I want to draw out what has been good about the last 10 years before we get into the further discussion. Prof, from your vantage point as a practicing one of our top doctors, and also highly involved in the management of our healthcare over the years, give me your perspective of what has been the pluses and the minuses of the last 10 years.
I think health insurance is extremely important, and I think it is perhaps the most important social intervention in the nation's history. This is what I see. Before, and we need support, political support from the very top. This insurance came into being because the then candidate Kufuor promised that if he became president, he was going to change things. So when he became president, he was personally involved and made sure that the insurance was established. And you gave the example from America. You know, President Obama knows the importance of insurance, so he himself is involved in this affordable health care. You know, America had the so-called act called the Obamacare. And I'm a little bit disappointed in our present president, his involvement. I think he should be involved. He should be personally involved, make sure that he understands the issues at stake, and make sure that the resources are made available for the National Health Insurance Authority. Otherwise, without that support, that firm political support, we're going to run into problems.
Yeah, but I think for him to become fully involved, can we, using your expertise as a practitioner, you know, getting Sylvester, tell him what has been the pluses and minuses of the last 10 years, and so that we move the discussion forward as to, because it's important for us to know, commemorating 10 years, what really have we achieved? Because we set out to abolish cash and carry, and from the professional's perspective, what has been the good of it so far?
The good thing is that Ghanaians are aware, that the insurance is good and they have to enroll on it. But with time, they lose interest and they lose confidence because they cannot access certain services, certain laboratory services, X-ray, and so on. And so they become frustrated. And this all has to do with money. If the insurance system is not giving the money that is due it, no matter what you do, we may have the best system. And I think on paper, if you look at Act 852, it's improved compared to the Act 650 of 2003. But these are all things very good on paper. But then if the insurance system, I mean, if we derive some money from VAT and then from Social Security, and Ghanaians may think that if the government says, oh, 2.5% of VAT will go to insurance system, Ghanaians think that from the VAT secretariat, the money goes straight to the insurance system. But it doesn't happen that way. It goes into a consolidated funds, and sometimes the government will sit on it or use it for other things and not make the money available to the insurance system. If this happens, then the managers of the system will have problems. And so this is, and that will make people lose confidence in the insurance system, and that's what is going on. I think that the people in good standing constitute 36% of the population. That is not good enough. And
that's a good cue. Sylvester, one of the biggest challenges that the scheme has faced has been the long gestation period between paying your money and joining the scheme. And I suspect this has been one of the problems that has affected re-registration for the scheme, because how have you dealt with the fact that sometimes people will pay their premium and it will take 8 to 12 months for them to become members, and in that time if they fall sick, having paid the premium, they have to still go and pay cash and carry until they are fully enrolled. How have you dealt with that problem? Because I believe that is one of the biggest problems.
Yeah, I think that enrollment has been a major challenge, but I'm also glad to say that we have surmounted that difficulty. The original arrangement was for individuals to register anywhere across the country, of course, to register anywhere across the country, and then data is transmitted from across the country to the center. Cards are printed, and then the cards are sent back to the districts and communities for distribution. This system has been dysfunctional. It has not been effective. And we have realized that no amount of training, no amount of improvement of this system could generate the necessary efficiency and, as it were, encourage people to carry on. What we're doing currently is piloting an instant issuance of ID card based on biometric data, which we have begun. We have had a pilot with our military and police service, and we are currently rolling out. This, we believe, would address that challenge. What happens now...
Why would you be doing pilot? After all, we produce biometric voters cards in a period of 10 to 12 days to cover the whole country. We have the technology.
Well, so it may seem, but the cards we are producing are different from the Electoral Commission cards. You would observe that the Electoral Commission cards are paper cards, A4 sheet paper cards printed on it. What we are looking at is a smart card, a card that has the microchip, a card that can keep data of subscribers, at least allergies, blood group, last visit to the hospital, and last treatment, so that when there's an accident and you have a card, at least the basic information about the patient can be, as it were, accessed from one's card. So we are looking at a smart card and a card that would also ensure that we have data integrity, a biometric card that would ensure that we're able to clean up the data and clean up double registration, what have you, to provide close to accurate data, which is required to develop policies to improve the entire health system.
I'm an engineer. An engineer. Give me an answer. When will people get instantaneous membership when they register?
It has started.
Army and police,
it has started.
Those are people who enjoy free things anyway. But I'm talking about the people who have to pay for the service.
It has started, and we are hoping that latest by the middle of next year, would have completed the registration across the country.
For everybody? For
everybody. Now, we are not going through a massive registration and ID card issuance. People have registered, people have their old cards, and those cards are valid. You only register and secure the new card on the expiry of your card or when you are renewing. so that we don't have a mad rush of people rushing to go and register. We're doing it on a piecemeal basis. In any case, when you look at the Electoral Commission, they were able to provide kits across the country. So we are not going along that budget. We are using a very modest budget to ensure that we achieve the same objective without necessarily spending too much. And
no,
also,
but you see, you're talking about re-registrations now.
I'm talking about renewals.
Yes.
I'm talking about renewals.
What about
if your card expires,
yes,
and you are going to renew, then you migrate onto
but
the
how
new
do you
card.
overcome the problem of 60% of the people not covered? If you could assure them of maybe 1 week from payment to membership, they might come back.
No, let me also explain that.
For new people,
let
for
me,
the
let, me
60%.
let me explain
Yeah.
that in order to avoid risk selection or adverse selection, by that we simply mean that you don't have a scheme with only sick people. The idea is to have everyone register to be able to pool resources. If you want to give instant access to the use of cards, then what you're going to do simply is to get people who are sick. People are only motivated to register in most cases when they are sick. Or we have had situations where people are admitted in the hospital and then they run away from their hospital bed to go and register with the hope that they quickly get the card to escape payment. Now, so the whole idea is to ensure that you serve a waiting time of 3 months when you register before you can access the card. We have also indicated that when you have a card which expires, you need to renew it early enough. If you renew it a month, more than a month beyond the expiry date, then you still have to serve a waiting time. This is to ensure that people register back to back. When it expires by December, by January, you have registered. You could even register the same December, the month of expiry, so that you could have continuous access to healthcare by the use of your card. So these are mechanisms that have been put in place to ensure that we avoid adverse selection. You cannot run a health insurance scheme.
You made it mandatory, so there's no issue of adverse selection because now, whether I like it or not, I have to be member.
Yeah, we now have to implement the mandatory nature of the scheme, and we cannot do that by the use of force or law. We need to have a strategy of doing it, and that we're going to implement again by the middle of next year. Now, how we're going to do it is that if you're going to open an account at the bank, we're going to have discussions with the banks. You must show your ID card, your health insurance card. If you are going for a passport, you must show your NHIS card. There are several things that driving license, you must go with your NHIS card. We will be implementing this.
So I'm going for my passport.
By the middle of next year.
I have paid my premium.
Yes.
My 3 months haven't come up. What do I do?
Once you have the card, that's enough for you.
No, I may not have the card. You say to take me 3 months.
No, you have the card instantly. We are now migrating on to the instant ID card.
Okay.
But you have the card instantly. You can only use the card after waiting 3 months. Once you have the card, you qualify to secure whatever social service you require. These are all
pedantic. Why do I have to wait 3 months if I can get the card immediately? And now, one of the positive things you've done under your new act is to move from belonging to a district to
a consolidated scheme,
where basically it doesn't matter where you are covered. That's a very positive development. And why shouldn't I then get immediate service if I get a card as I do it?
That is what I said, that to avoid adverse selection, so that we don't have a scheme full of sick people. It does not sit well with the whole concept of insurance. The principle of risk pooling and subsidization and all that would have to be fulfilled, and in order to ensure that we fulfill all righteousness.
Prof, what's your comment on this?
My comment is, it's a good thing they are introducing another card. But again, Ghanaians are going to be burdened with cars. Too many cars. Health insurance card, social security card, passport, driving license.
Anti-ghost names card for the civil service.
That kind of thing. So that is why I'm saying that in all these things, you need some form of political, governmental support. There must be some consolidation of cars so that when you have one card, one smart card, it will work. But if the government is not up to that standard, health insurance can do it. Why not? But I want to go back to something that Sylvester mentioned earlier on, that as of now, 88% of incomes from certain hospitals are derived from insurance payment. And that is good.
No.
That is good, but that is also a risk. If a facility depends upon the insurance for 88% of its budget and payments are delayed, then we are bound to have certain challenges in the schemes and also for the providers. And I think, again, I'm talking about cash. If the insurance company system is resourced, and I don't think the government is doing that. So we may have financial difficulties, but what I want to appeal to the authorities is that make the monies for the insurance system available to them so that they can run this all-important system. Without money, nothing can be done. And one thing too that is drawing us back is that of accessibility. I mean, the insurance system is there, but how many Ghanaians are able to access hospital without struggles? We have to look at that before. And also how the health systems are also managed. One thing I also want to talk about is the fact that the manufacturing base is so low that the hospitals run into problems. Everything that is used in the hospitals is imported. If you have to import syringes, you have to import gauze, plaster, every cleaning material, then we run into problems. So people cannot get good health care, and then they have less confidence in the insurance system. So much as I agree that the insurance system provides 88% of income for certain hospitals, I think that in itself is good, but it can also be a risk in the sense that if the monies don't come, then the systems will suffer. So again, Mr. Government, please make the insurance system, resource the insurance system so that they can achieve their mandate.
Good point. Can I get in here now?
Yeah.
Why is the money not coming? Statutory deductions, 2.5%. Incidentally, I made that suggestion to President Kufuor about the 2.5%. This is statutory deduction. Statutory means it is meant for your purpose. In our documentary, we interviewed a lot of service providers, and many of them have said to us, listen, our banks are no longer willing to give us any money to run our operations because we haven't been paid for 8 to 12 months. As the chief executive of the NHIA and a former member of parliament, should we be in a situation where statutory deductions are not going for the intended purpose and therefore collapsing the NHIS system?
But
Well,
I don't think you're...
No, he's a chief executive, so he may have an insight into it.
Let me say that a lot of allusions have been made to government support. I think that you will recall that sometime last quarter of 2012, His Excellency the President gave a directive to the Ministry of Health and the National Health Insurance Authority to engage stakeholders to discuss two key issues bothering the health insurance scheme. One was one-time premium, and two was sustainability. We had an extensive stakeholder engagement that brought into this country external facilitators and practitioners to discuss, to analyze the health insurance scheme in Ghana, discuss...
I don't want to stop you.
It will be useful to... I'm coming to your response. I'm coming to the response you require.
Because people are not getting paid and the service is collapsing around us.
I'll get there.
Yeah, okay.
I'll get there.
Right.
So we had this stakeholder engagement, and there were a number of decisions that came out of this, or suggestions that came out of this. These decisions or suggestions or recommendations that came from the stakeholder meeting on one-time premium and sustainability are currently being discussed. The National Health Insurance Authority and the Ministry of Health and government are working on some of these recommendations. So I think to that extent, government is fully involved in the National Health Insurance Scheme. Number two, with regards to payments to subscribers, it's also important to appreciate that releases to the health insurance scheme is usually done 3 months in arrears. And so it stands to reason that there would always be a kind of lag between when claims are submitted and when payments are effected. Again, you know as well as I do that the Internal Revenue Service reconciles its collections, and you even get to know what has been collected after 3 months. All these are done 3 months in arrears. Perhaps we want
But service providers are 8 to 9 months in arrears.
they're currently about 4 to 5 months in arrears.
I've spoke to a few before I came on the program.
There is no service provider 9 months in arrears, and I can say that
most of them have not been paid since April.
On authority.
April was the last time they were paid.
All April claims have been effected. May claims have been paid, and we are currently processing June claims. We have also indicated that any provider that has any challenge with regards to payment, at least for the periods that we have paid, should quickly link up with us. We have realized over the years that we have isolated cases of providers who get lost in the process. One, because perhaps at the time of submitting claims for April, their claims were not submitted, so April claims were paid and they were not paid. So we have a number of such isolated cases. But generally, we have paid all providers for the month of April. We have paid providers for the month of May. We are currently processing that for June. And we're hoping...
Isolated is not a word that I hear on the ground, because a lot of service providers are quietly and some publicly returning to cash and carry. That is a fact. So it's not isolated. And I think that, you know, we should, to quote Rawlins's recent words, not play ostrich. It's a major problem. The scheme is, we've all agreed, very good. There's total political support for it. It is refreshing that the kind of political dogfight that beset the scheme at the beginning is all gone. But if we're not careful, the reality of a creeping return of cash and carry, and we don't address it.
We certainly have sustainability challenges. Yeah. Sustainability challenge
that,
in the sense that our outflows exceed our inflows. So we have a challenge. But I think that Prof, I guess Prof may have some facility somewhere that he can comment on whether payments have been made up to May. I don't know.
Yes. I mean, that is quite true. I mean, I'm part of a facility in the Ashanti region, and in that district, payments have been...
up to when?
Up to,
May.
I think, May or June. May.
And is that facility getting into cash and carry, or is
No. It's a rural facility, and, you know, as you said, you depend upon the insurance for quite a substantial percentage of your income. But I want to go back to...
Prof, before you even come in, let me say that we are not, as it were, satisfied with the fact that providers have been paid up to May, June, when we are in when we are in October.
Yes.
I would want to take advantage of this forum to apologize to providers across the country and to assure them that we are not oblivious to the challenges that they face, and that we are working towards ensuring that we close up the gap.
That is precisely the point.
Yes.
I mean, I will not fault the money, yes. I don't their fault at all. If the money is there, they will pay. And so, if release to the insurance system is done 3 months in arrears, that is not good enough. You know, so, again, the authorities should come in and make sure that the Internal Revenue Service or whoever is responsible for collecting the money should make sure that it should not be even more than 1 month in arrears. The system should be made functional so that this all-important social intervention will succeed. And that is why I say that the president should be personally involved, because all over the world, President Kufuor was involved and said, I want an insurance system. And President Mills was also interested in the system. So I expect President Mahama to also be personally involved, make sure that payments to the insurance authority are made on time so that this 3, 4 months, 5 months delay will be a thing of the past.
If one can sort of give a little pardon, part of the problem that they are beginning to see is a lot of false claims, which adds to some of the delays
Yeah,
with that.
That is true, and they've done quite a good job. You know, if they've set up, that was not there when the insurance system came into being, vetting the claims and so on. There's now a whole department doing that kind of thing. That is commendable. But again, that aside, inflows into the system are 3 months in arrears, and that is not good enough, and the government should do something about it. And that is outside the authority of the Health Insurance Authority. And so Internal Revenue, Minister of Finance or Health, whoever is there, should please resource the insurance system on time and adequately so that they can fulfill their mandate.
Okay, you're getting some flack from some NGOs, etc. There's a perception that it is not getting to the poorest, and that essentially because of the way it's funded, the provision is going to those who pay SNIT contributions. And the poorest in the society are not benefiting from what is meant to be a social engineering project. Is that true? And I mean, Osfam, for example, has been very vociferous in commenting about the state of our health service and the whole issue of using health insurance as a basis for creating health for the poor.
Well, I wouldn't go into the an ideological discussion.
Not so much ideological.
But there are several viewpoints with regards to how to run a health system, and in particular how to ensure effective financial risk protection.
No, I'm asking a very direct question. I mean, how are you reaching the really poor in Ghana with the system? That's the question I'm asking.
Well, the health insurance structure that we have, our architecture provides for an exemption category.
Yes.
Which is unique, looking at what pertains in other countries. Our health insurance scheme in Ghana is different from that of any other.
I know.
We have an exemption regime that provides exemption for all those 70 years and above. It also provides exemption for all those below 18 years. It provides exemption for expectant mothers or pregnant women, and also provides exemption for the poor and lead beneficiaries and indigents for that matter. So there is an inherent mechanism to, as it were, accommodate the poor. One can easily say that, well, perhaps we suffer from equity challenges because below 18 years there may be a number of people who have the resources and who can pay premium, but who under this blanket policy are exempted. The same applies for pregnant women. A woman drives in a Benz to the hospital, and because of the blanket policy, she's exempted. Again, the same can be said for 70 years and above. But at the end of...
This is very good. So why is your communications expert saying that people need to re-register? If somebody is on pension, you know they're not going to reduce their age. Why do they need to re-register?
Yeah,
why can't it be a permanent thing?
Yeah, you need to have a card. Yeah. We need to track the usage. We need to track utilization. We need to ensure that you are on the scheme. We need to know that you are renewed.
Why do you need to renew if you're a pensioner? Why should a pensioner need to renew? And one of my workers here is telling me that they have to register their 1-year-old child. These are real user issues that are coming up.
So with regards to
a pensioner having to...
With regards to the element of the poor that you mentioned, we have an inherent mechanism that
I have read that in the law.
That addresses the poor. But that notwithstanding, we are also embarking on some deliberate efforts to ensure that we reach out to the poor who have failed to get into the net through the exemption regime. And in doing so, we are operating in collaboration with the Ministry of Gender and Social Protection, which has a mechanism for targeting the poor. So all the poor they target the data or information is forwarded to health insurance, and then we follow up and do the registration. We have gone to all the mental homes across the country. We have registered all of them. We've gone to all the, I mean, just in a bid to ensure that we reach out to them. So there is a deliberate effort to ensure that we reach out to the poor. But of course, we cannot say that we have all the poor in the net. So again, it is an ongoing process.
Prof.
Again, I mean, you see, the managers are excellent. No question about that. On paper, everything is good. We want to reach the poor. Everything has been done. But look at Ghana's expenditure on health. I mean, I've got these figures from the Economic Intelligence Unit. Our per capita expenditure is $90 US. And total expenditure on health as a percentage of GDP is 4.8%. And this ranks Ghana number 167. So when it comes to health expenditure, we are 167 out of the 180 or 200 countries. So it is extremely low. Now, if you have these figures, no matter what you do, you can register all the poor and do all the interventions, and still it will not be adequate. So our problem is not what we have on paper, but the problem is money, cash. And so this country has to generate wealth. The way our economy is, we cannot maintain this system, no matter what our good managers are doing. Even the little money that is coming to them is not coming. And even when that comes, it's not adequate. So we need to create wealth and manufacture things so we can add value to the things that you are doing. Otherwise, no matter what you do, we'll still be dancing in circles. The Germans call that Affentanz.
Affentanz, yes. Okay. So, Oscar,
the monkey dance.
Anyway, we're coming to the end of the program, and I want to just touch on, the future. Last Thursday, you're very sharply dressed in Parliament. I saw the pictures. And you are telling the Public Accounts Committee that by 2015, you'll be running a gap of 500-odd million Ghana cedis. And yet you are also giving assurance that the sustainability of the scheme was assured. Can you please explain how you square the circle?
Well, let me say that we have usually approached the concept of sustainability perhaps from an angle that generates so much fear and panic. Every social protection policy must keep the finger on sustainability. Sustainability because it is not a natural policy or program for that matter, and it requires a conscious effort to sustain. It is therefore incumbent on any social protection policy or management of any social protection policy to constantly undertake actuarial analysis to review the sustainability of the scheme. Sustainability is not defined in infinity. Sustainability is defined within time frames. And getting to the end of a time frame, it has to be reviewed.
But it's getting worse by your own numbers from now until 2015 and
But
beyond.
what is important is that government is in discussion on how to, as it were, review the sustainability of the scheme. So to the extent that government is in discussion, or we are in discussion with government, I mean, unless we want to say that government has collapsed, to the extent that government has not collapsed.
Government is broke.
To the extent that government has not collapsed, one cannot say that there is a crisis.
There is a crisis. From discussion to action, the numbers that the professor has given us are frightening in terms of the commitment. But the last word, let me have your last word, and then I'll give one to Sylvester, because we have to round up.
Again, I pity them, If you look at the fact that 80% of inputs into agriculture, education, and health is from external sources. 80% of inputs.
We have to round up.
Agriculture, and then, as you're saying, outflows exceed inflow. And so we need cash, money, kudi, to run the system. Okay. And it cannot be better than the government.
Sylvester, thank you very much for 10 years. We wanted to spend time to discuss your new vision, but we'll probably come back to it another day. It's important, social engineering, and we need to make sure
I
that
haven't
it
taken
doesn't
my
die.
last word.
Yes, go on.
We want to assure all our subscribers, first to thank them for their kind indulgence and to assure them that we are working on all the challenges that we have discussed with them, and we're hoping that by the close of this year, most of those challenges would have come to an end. We are having an international conference between the 4th and the 5th of November. We are having all the leading speakers on health insurance and areas bordering on the health system generally. And our expectation is that we would have some useful knowledge sharing arrangements to redefine
Our time is up.
our way forward.
Thank you very much.